welcome to the Medwire News podcast. In this first of a two-part edition, we talk to registered nurse and certified diabetes educator Lori Berard about the barriers to the initiation of insulin in patients with type 2 diabetes. Recent years have seen a plethora of novel insulins appearing on the market, but Lori stresses this has had very little effect on the fundamental issues that healthcare professionals need to address with their patients.
The barriers to insulin therapy have, interestingly, not actually changed that much in the past 10 years. And when I say that about the fact that they haven't changed, insulin therapy in the management of diabetes has certainly advanced over the course of the last decade. While we now have newer, flatter basal insulins that act longer, have less hypoglycemia, we still have patients who have the exact same barriers as they did 10, 15, 20 years ago. Fear of injections, fear of weight gain, fear of hypoglycemia, concerns about the complexity of therapy, and also the sign that insulin is failure in managing their disease and that their disease is that much worse.
And are there any barriers from the healthcare professional's point of view?
Theoretically, the barriers to insulin therapy have improved. But in fact, the rate of initiation of insulin has not changed that much in the past decade. And when we think about a busy primary care practice, there still continues to always be lack of time, and that's always cited as one of the reasons for not initiating insulin. Lack of support. We know that it needs to be a team effort. It's very difficult for a solo practitioner to start insulin and to go through all of the teaching. Also, the complexity of insulin. So even though we have now introduced initiation protocols that make the message very clear, there's still a lot of fear of the actual starting of insulin in individuals and then the what next steps. So we become a bit more inert. And I also think that one of the barriers to insulin therapy in the last decade has been the advancement in the overall diabetes portfolio in terms of other medications which make it easier to prescribe another tablet versus going on to insulin therapy. So we are delaying insulin just as long in 2017 as we were in 1997.
When do you feel is the best time to start talking to your patients about insulin?
Having the conversation about initiation of insulin in someone with type 2 diabetes really should occur almost at diagnosis of diabetes. The ability to communicate how diabetes changes with time and how insulin could become part of the therapy. I always say in 5 days, 5 weeks, 5 months, 5 years, 15 years from now. But I really think it's important to raise insulin as part of the management conversation early in the course of the disease. If we just wait till the very end of the, sort of all of the options are gone and now we're going to do insulin, then that makes it like the end of the road. But when we include it as a treatment option all throughout in the discussions, whenever A1C is above target, insulin's always an option for patients, we help to normalize it a little bit. But most importantly, when we have the conversation about insulin, we really need to explore with the patient what their fears might be, because often they know someone who's gone on insulin, who has had a significant complication or something fatal happened shortly after they started on insulin, and that's the fear they carry. And we need to understand that to make sure that we address those fears and help the patient understand that doesn't need to be their journey.
Do patients often have other concerns that you need to address?
For many individuals starting insulin therapy, there is a definite fear of hypoglycemia, weight gain, and this underlying thought that their diabetes is actually progressing. I think these are very important conversations to have, especially talking about progression of diabetes to start. So if individuals feel that starting insulin therapy means their diabetes is getting worse, it's important to have the conversation about achieving their personal glucose targets and what that means. And if they have not been at target, that getting them to target will in fact delay the progression of their complications. So it's about putting into context the management of glucose, with insulin in this case, achieving targets, and actually preventing the progression. When we think about weight gain and hypoglycemia, weight gain is something that can naturally occur when we go on insulin because we store calories. Let's then have the conversation about healthy lifestyle, being more physically active. And of course, weight gain will occur if individuals are having hypoglycemia and they have to feed it. So it's kind of a hand-in-hand conversation. We address how to prevent hypoglycemia by having slow increases of insulin over time, not big jumps. We talk about identification, prevention, and management of hypoglycemia, and early detection to be able to adjust an insulin dose, meaning there's less hypoglycemia, can actually lead to less weight gain. So all of those things really are part of an overall conversation. Using insulin to achieve a target to reduce the progression of complications, using the right insulin dose to make sure that we don't have hypoglycemia, and then also being healthy in our lifestyle integrated into the insulin therapy to prevent weight gain. So it's all part of the overall conversation. It isn't just about the insulin dose.
And what else is important to discuss to ensure a smooth and successful transition?
It is really important to consider the other barriers that patients might have besides those of weight gain and hypoglycemia. Many individuals have a fear of injection. They are worried about the complexity of the therapy once they go on insulin. Everybody thinks that insulin is just that much harder to do. And they also believe it's more expensive. So thinking about how we can address those barriers in patients, it's important to, again, understand how they think insulin's given, what they think the needle looks like, what they think is the issues around complexity, and then, of course, having the cost conversation with people. So, for example, many people may think about insulin as being vial and syringe. They may think of the needle as long as their immunization needle, and they may think that they have to do so much more now that they're on insulin therapy. Explaining that we use the smallest, finest needles possible, that we have devices that are insulin pens that they can dial up the dose. And often when we start insulin, people with type 2 diabetes, it's once a day. And so the complexity is not that difficult in terms of the actual need to give an injection. And then the amount of blood glucose monitoring is individualized, but we aren't asking people to go out and do 4 shots a day and 4 blood glucose tests and make calculations. Keeping the conversation very simple in terms of how we're going to do this, that it's 1 shot a day and we need at least 1 glucose to titrate. Demonstrating the injection with the patient. So let's see what this feels like. Let's show you what this needle looks like, and let's try it before you actually have to do it on your own. And then in terms of the cost, unfortunately, that's something that changes depending on the countries that you live in. But often when we figure out the cost of insulin, it's significantly less than some of the oral agents, depending on the type of insulin that's used. So keep the message simple, be upfront about how we can do this to keep their lives as on track as possible, not making it too difficult, making insulin fit into their life, not their life fit into insulin, and always assessing how people are feeling in terms of the complexity, because it can be overwhelming.
And that wraps up this edition. Thanks very much to Lori for her insights.